Welcome to Big Ideas in Eating Disorders. I'm Kathy Pike, a clinical psychologist, longtime faculty member at Columbia University, and your host for Big Ideas in Eating Disorders. Today's session is part of a larger series with authors who have contributed to the book that Ruth Weissman and I have co-edited that also goes by the name Big Ideas in Eating Disorders. The aim of this podcast series is to have a chance to chat with contributing authors to have a better idea and further understand the big ideas that they contributed to the book and really understand more the origins and the aspirations of these ideas. So today I'm thrilled to be joined by Professor Phillipa Hay. Professor Hay is the Foundation Chair of Mental Health, Western Sydney University, and Director of Mental Health Research at Southwestern Sydney Local Health District. Her co-author is Professor Deborah Mitchison, who is Associate Professor in Psychology at the Graduate School of Health, University of Technology, Sydney, and she also holds adjunct appointments at Western Sydney University and Macquarie University. So, Dr. Hay, to get started, can you just share with us at a very high level, sort of what is your big idea? And then we'll dig in a little bit more about where it came from and where it's going.
Well, my idea was to reimagine how we think about classifying and diagnosing people with eating disorders. And it really came about through the current really quite confusing way we have of making diagnoses that is based on really historic premises rather than sort of growing from the ground up. It also came about through just the way I communicate and talk and think about eating disorders to people I care for, to their healthcare providers, that fundamentally an eating disorder is something that's experienced as a problem with eating, a problem with dysregulated eating in various forms, whether it be highly restrictive eating or loss of control over eating, that has consequences for the person and causes distress and impairment for them in terms of their daily function and the way they relate to both themselves and perceive themselves, but also their relationship with others.
And so it's a pretty radical idea, right? And it's true that our classification system is a legacy system, right? And we use it because we've always used it. But it's a pretty radical idea to say we need to rethink how we do this. So as you have evolved this idea in your own research, in your science, and in your clinical practice, these ideas have been evolving for a while for you. Where did Debbie come in and how did the ideas evolve, or what complementary conversations have you had about this that got us to the chapter that is part of our book today?
Well, the most recent things that have been happening were when Debbie was a scientific convener of the Australian New Zealand Academy for Eating Disorders scientific meeting, and I was asked to speak on classification. And so I worked with her and the scientific committee thinking about that, and then I thought about what I would say. And so I really sounded out the ideas with Debbie at that level from about 2 years ago, I think, 2 or 3 years ago. And I've been sort of talking about it ever since, because what I said essentially is now really in the book chapter. It really comes from what I said at that conference, and the impact also that I had with people with lived experience, and in particular an author, Fiona Wright, who was a poet, and she had made a podcast for me about her experiences with eating disorders. But one thing she really touched on in a major way was that meaning making of diagnosis. Mm-hmm. And she talked about it as something that was crystallized for her, like stars in the sky. And I sort of use that metaphor in my talk. So really that's how Debbie and I started to really talk together about it. And as I said, she shares that passion that I have, that we need to, maybe it won't be this one, but in some way we need to reimagine and our way of diagnoses and classification schemes, because there's so much confusion and so many problems with the current scheme, and it does not resonate with people who experience eating disorders.
So when we think about classification and this comment that Fiona made of meaning making with diagnosis, we hear from individuals who live with eating disorders that sometimes it's very helpful to have to know what, it's helpful for me to know what I have, so to speak. And for others, it's really quite alienating, as you say. And as I'm hearing you and from the chapter, I understand you're not saying classification, all classification is bad. We need a new system, right? We need to rethink how we do this. So what would you say are the critical components of what needs to change in the way we think about classification for it to be meaning making in a positive way versus alienating?
I came to this really very early in terms of my doctorate at Oxford was on classification of binge eating disorder and recurrent binge eating. So I came to it from a very academic perspective, and I'm indebted to Professor Fairburn, Chris Fairburn at the time, who was my mentor, who really had a very rigorous approach to any sort of research that was done. So that's where I came from. And the importance of classification was that it has to be meaningful. It has to describe, encompass an experience that is in common with other people's experience enough so we can classify, so it can't be a completely unique experience, but there are commonalities that are enough that we can then communicate both to people living with the disorder, but also to their healthcare professionals, what that is in a rigorous and valid way, so an accurate way as well. So it has to be accurate as well as being meaningful. And accurate in terms of it gives us information. It tells us what might work in terms of treatment for the person. It tells us what their outcomes might be over time. And it gives us an understanding of how it is that they may have this disorder as well. So what are the things that are shared with other people with the same disorder? So that's really where I came from, that kind of more high-level academic understanding. But then, as you intimated, I realized when I'm working clinically with people or working with my colleagues that it's just so very fundamentally important, because not having good diagnoses means people might not get treatment because they don't fit the diagnostic criteria. And we've seen many examples of that in the eating disorder field, where services will treat people with certain disorders but not treat others. So they say, well, we'll treat people with anorexia nervosa, we'll treat people with bulimia nervosa, we might treat people with binge eating disorder, or we might not, because we might not have sufficient resources at the time, and perhaps somewhere else we'll treat people with binge eating disorder. And they don't understand, and it's, we had this confusing, used to be called eating disorder not otherwise specified. It's now called other specified feeding and eating disorder. So we have these confusing categories as well, which might or might not help people to access treatment, because they might or might not fit into those either.
Mm-hmm. So how does your suggestion, how does your big idea improve on what we've got?
Well, I would say it would mean that we would see and treat people who have eating disorders, whatever the particular defining features of those eating disorders are, but we would also have an understanding of those for the persons, because we know there are differences with certain defining features of highly restrictive eating disorders and disorders where there's a high degree of loss of control over eating or binge eating. We know that they share some things in common, but other things not so much. We know there are genetic heritability differences, for example. So this new system would allow for that. It would allow, so we don't lose all the knowledge we have about anorexia nervosa, bulimia nervosa, binge eating disorder. Those disorders can map into this new way of thinking. And so we don't lose all that knowledge, but an understanding of how there may be differences across the spectrum of eating disorders. as well as many of our treatments have been developed based around certain eating disorders. So we wouldn't lose all that either. We could say that this type of treatment will be, helpful. There have been empirical trials in this type of eating disorder that you have. But fundamentally, you have an eating disorder.
Mm-hmm.
And this is how it's being experienced for you.
Mm-hmm. And so, as you mentioned, Christopher Fairburn, Dr. Fairburn is an important mentor in shaping your thinking. What would he think of that suggestion? If you talk to Chris, I know Chris has retired from the field, so I don't know that he would opine on the topic, but what do you imagine he would say?
Well, I can sort of imagine, because when I presented my thesis to Professor Gerald Russell at the time, who was very much a major person, he was one of the examiners, and he just said very sagely and very kindly that it might not turn the world on itself. There are there are a lot of forces out there, and I think those forces, that the investment people have in the current schemes, as you said, the legacy, they're very, very strong.
Mm-hmm.
But I'd hope it would actually nudge towards some change in direction, and I think there is now a much more shared understanding in the field that something needs to be done. Because of the major problems that we have, the overlap in diagnoses, diagnostic categories, the confusion, people don't understand. Actually, Professor Fairburn might like that I'm a sort of bit of a champion for the non-purging form of bulimia nervosa, which has constantly got lost and confused with binge eating disorder over time, because people think that bulimia is the purging. And that's what bulimia is. So that's one of the major confusing things that's going on. So he might quite like that, I think. I hope, anyway. But, I think if it just actually starts me to think we could do things differently. There could be another way of doing this, whether it's this way or another way. But really something has to change because, as I said, it's confusing, there's overlap, and it's very for people with lived experience who get told they have, by one healthcare professional, they have got bulimia nervosa, another one says, no, it's binge eating disorder, and then that changes over time so that they may experience anorexia nervosa, bulimia nervosa, binge eating disorder, can all be experienced by the same person in the course of their journey with an eating disorder. And then, of course, they're getting different diagnoses all the time. So I think really there is probably agreement that something has to change, something has to be done differently, because this is confusing and it's invalidating for people to be told, they have one disorder, no, they don't, they've got another one. Yeah. Or you can get treatment this week, but not next week because you've fallen in and out of a diagnostic category.
Right. So you've been thinking about this for a long time. If this was your training, right, your thesis with Dr. Russell and Dr. Fairburn, what do you think makes it possible to push this idea forward now, right? Dr. Russell said, well, I don't know if this idea is really going to make it in the world right now. We've got all of these entrenched systems and ideas and structures that we become quite enamored with, right? So you're challenging the legacy now, but you've had these ideas percolating for all the way through your career by the sounds of it. So what makes it possible to get airspace and get page space and actually say this now? What do you think the conditions are right?
Yeah, I think we missed an opportunity with the DSM-5, and I think that was an opportunity that was missed. I think there was discussion at that time of doing things a bit differently. There was some minor revisions too, but really things didn't change. Minor tweaks, etc., but really things didn't change. So I think there was that missed opportunity. I think some of the ideas kind of got in there, and some of them got into the ICD-11 revisions, and certainly this idea of not being so prescriptive about what is a binge, whether it's a small or large amount of food, etc. That's got in there with the ICD-11. It didn't get into the DSM, but some of the ideas have kind of got in there, and I think the idea of anorexia nervosa being more across a weight spectrum as well got into the ICD and not perhaps so much into the DSM. That's another one that's been percolating around, is taking, you know, the emphasis on weight out of eating disorder diagnoses, and particularly out of anorexia nervosa. So some of them have been percolating around, some of them have there's been sort of little steps. What would take a major push, I think, is to really get the field together at a high level. I think there are opportunities now with the way the DSM is structured, that it's not quite so wait for a DSM-6. There's possibilities 6 could happen before a DSM-6, and are happening, and there's been discussions about that happening in other disorders within the DSM, that there could be a DSM 5 point something that encompasses a rethink about eating disorders. But the other thing is, I think, really the impetus and advocacy and involvement of people with lived experience at a high level in these sort of discussions and within the field. And that is something that's new, that's different. And I think that leads to change. And that can lead to quite rapid change than our sort of, you know, dusty old academics who pontificate about things. But, you know, you get people with lived experience coming in and really talking about it and being involved now at high levels. I think the International Journal of Eating Disorders now is requiring people to address how they involve people with lived experience in their research when they're submitting a paper. So that's been that's really reflects this major change. And I think that gives me sort of hope and anticipation that things will change, because I think it's going to come from the people with lived experience as much as from the academics.
Yeah, I think often with big ideas, there's a moment, and it seems like it happens very quickly, but it actually has been happening for a long time before there's visibility of movement. And it sounds like that is the case for you, certainly. And I would, as you describe the field, it sounds like the field I also know. I would agree with you that this has, you know, been going on in the ways that you described. I wonder, Phillipa, if you could share what is there a particular misperception or misunderstanding about eating disorders that you think is really problematic, that this revision of how we classify disorders will address most effectively?
Yes, I think it's what is an eating disorder. And I think that perception is still very much in people's minds, that it is a disorder of people who are clinically underweight and highly restrictive. People have, you know, the classical form of anorexia nervosa, whereas majority of people with eating disorders are not. In fact, may well be higher weight as well. And on the other hand, there's a perception that it doesn't really happen. People are very high weight, that their problems with eating are to do with their inability to control themselves, or, you know, the stigma around people with higher weight, etc. So there's been a severe underdiagnosis of eating disorders, I think, across the weight spectrum at the higher end. And you know, really view that the only real eating disorders are those at the lower end with anorexia nervosa. So that's been one thing. I think that's been really an impediment to understanding. And we have strong advocacy from people with lived experience in Australia that anorexia nervosa occurs, that atypical anorexia nervosa is misnamed. They don't. And the term atypical is actually stigmatizing. It's actually saying there's something different about you, whereas in fact it's the same disorder. It's just some people of more adequate weight who are not severely underweight. So that's one of the main myths I think that's around, and that doesn't help people who have atypical anorexia nervosa to say, well, you have an other specified, you don't quite have anorexia nervosa, so it's not quite as kosher, if that's the right term, not quite as real a disorder
Yeah.
as anorexia nervosa is, which is not at all to say anorexia nervosa is not a real disorder. It is absolutely,
Yeah.
a very serious disorder, but it's part of the spectrum of people with eating disorders.
So you've put forward this framework that you elaborate in the book in more detail that you hope will bring clarity to our classification system, will improve our classification strategies. But people are complicated, right? And these disorders are varied and complex. And what if you're wrong? What if we just have a different kind of mess? Or what would be in what ways, what are the risks that it's a great idea, but it's actually not going to work?
Well, that's where I'm really indebted to Debbie
Yeah.
because she put forward a really beautiful way a rigorous way of evaluating it. And it needs to be evaluated. It needs to be trialed. It needs to be tested and modified as a consequence. I don't imagine that testing and validation will end up with exactly the same thing. We shouldn't. We should end up with something that's better and that works. So that would be my premise: is that you have an idea, but it needs to be tested, validated, modified, developed, and then it will work.
Right. So Debbie, as you think about her primary contribution to the chapter, can you elaborate a little bit more about evaluation? What data do we need, or how would we get the data we need to know what's working with this new idea, this big idea, and what needs to further refinement?
We need to test it out with people experiencing eating disorders. We need to see how it would map onto their experience and how it would map onto the current scheme, and how it would actually work better or similarly or not as well as the current scheme. So we need to do those sort of comparative studies. We need to also have conversations and what we call sort of more the qualitative feedback from people with lived experience as to what this means for them, how it would fit for them. Would it be also from healthcare professionals? Would it be something that they can use? Has it got clinical utility? So if they're given various experiences or scenarios and they're making diagnoses, could they use this to make a diagnosis? How easy would that be? How useful would it be? And then how accurate would it be? So in a longitudinal study, is it predicting? Is it telling us what's happening over time? Is it sensitive to change? Does it show how people may recover over time from an eating disorder? So we need different types of research and a series of studies that would involve both what we call the sort of qualitative methodologies as well as the quantitative methodologies, the sort of hard number crunching, that this is actually something that's robust, it's reliable, and it's predictive of outcomes.
And if you weren't doing this work, Phillipa, what are there other aspects around eating disorders that call to you, or even beyond eating disorders? If you weren't in the field of eating disorders, what would you be doing with your days?
I think I would be a psychiatrist. I suppose if I sort of take myself to whether I would still be a psychiatrist, but I think I would have probably trained in psychoanalysis, probably, which sounds a very old-fashioned thing because that was sort of what was when I was around, or the sort of in the psychodynamic psychological therapies. I probably would have moved into that field and probably done, because I'm an academic, because I like asking questions, I'm sure I would still have been doing academic evaluations and research around that, but that's probably where I would have been. I think probably working much more as a psychotherapist predominantly.
And was that on your radar when you were doing this work with Dr. Fairburn or Dr. Russell? Were there
Yeah,
lots of psychoanalytic centers or teacher training programs?
Yes, it was. I did do a psychodynamic and extended. Well, I did training in psychodynamic therapy during my training as a psychiatry registrar in Australia. But when I was in Oxford, I did do a further training in dynamic therapy at Oxford. That just in my own time, just that was offered to the people in the department. So yes.
So you did this psychodynamic training. How do you think it enriched your thinking about classification?
Well, I think it always reminds us that classification is only part of the understanding of a person, the diagnosis. And the diagnosis occurs in a person with a unique experience and unique narrative. And so that's what I call the context of the eating disorder. So it's their life experience. It may have included trauma. It may have included various invalidating experiences in their formative years. It may have included environmental exposures and experiences, some of which are common and what we call risk factors for an eating disorder, such as training in classical ballet. I love the ballet, but it's one thing that always comes into my mind. Training in classical ballet is something that puts, people at risk for an eating disorder. So I think that's the dynamic perspective, is that the diagnosis is not the end. It's the beginning of the understanding and communication about a person, about their experience, and about what might be helpful for them. And it can help us understand why some treatments work apparently equally as well, for example, for people with anorexia nervosa. And I'm thinking of the classical trial by Stefan Zipfel and others in Germany, where they compared psychodynamic psychotherapy with cognitive behavior therapy that had been developed by Fairburn at Oxford. And the number crunching, people seem to do equally as well. But on an individual basis, perhaps not so much. Perhaps there are ways we can sort of then tailor a treatment. We know that there are treatments that work, but which ones will work for you, or which ones we might think and have a hypothesis might work better for you based on the context of the eating disorder for you as a person.
Phillipa, you've been at this work for a long time and have worked with lots of people, helped many people both as a mentor, an academic mentor, and in your clinical understanding of these conditions. Are there any individuals who shared with you their own experience of their eating disorder and the experience of diagnosis that were significant to you in catalyzing your thinking or changing your thinking?
One person who comes to mind particularly is Fiona Wright. She's a poet and an author, and she was at Western Sydney and did her PhD in creative writing around short essays, which were her journey with an eating disorder. So it's both meeting Fiona, talking with Fiona, and also reading her writings. So, as I said, she was the one who I interviewed her and did a podcast where she talked about the vital importance of a diagnosis and of understanding also that she has a spectrum of autism as part of that diagnosis, which came much later, but it made things clear for her as to understanding why she found group so difficult when she was an inpatient, for example. So that's been really important. I think that lots of things that she has reflected on that I often quote when I'm giving lectures. One thing she reflected on was just an understanding of the underlying neurobiology of eating disorders and why, when she was in the sort of full thick of the anorexia nervosa and very unwell, that she couldn't write what she called the long form, that's essays. She could only write short form, which is the poetry, because her brain wasn't working as well.
Yeah.
Her brain could not sustain writing the essays. And so it was in her recovery that she began to be able to write the essays and wrote her autobiographies, which are in short essay form. So things like that, this importance of, we often think, psychoeducation, okay, that's something we do, it's interesting for people, but it actually has meaning, and it can have very particular personal meaning. And for her, that was her ability to move from poetry to the essay form.
Mm-hmm. Phillipa, you've thought about these issues for a long time. You've contributed substantially and importantly to the field. Are there things that you think about that you wish people would ask you about that they just don't? Are there critical issues in the area of eating disorders that are on your mind that we want to bring out?
Well, I don't think there are things that people don't ask about or we don't talk about, but I think one of the critical issues is really saying, what is it that works well for people and why? And I know Eureka Schmidt, I talked with her about this, and I know she thinks a lot about this as to why the therapy they've developed, why mantra might work perhaps for people with more severe spectrum anorexia nervosa than for others, because that's something she's been investigating and finding out as well. So that's one thing I think that I know others do talk about and think about, but I think we all need to be all the time, and moving away from advocating for or saying, I have the therapy that works and it works really well, and I don't understand if people doesn't work for them, well, there's a problem for them. It's a problem. They have the problem, not the therapy. So I'm involved with research at the moment where we're looking at family-based treatment, which works very well for many people, but not for all. So what the research we're involved with, Janet Conti and others at University of Melbourne, is trying to work out what it is that's not working for people, where it doesn't work, and how it could be made to work better, or alternate therapies be made to work better. So that's something that I'm also very passionate about.
Yeah, I share your distaste for the shorthand that people use that say, oh, she was a treatment failure, or as if the individual failed rather than the treatment failed. And that's hugely problematic. Yeah. Last question. What's something that about you and your work that others don't know and might find surprising?
One thing I think people don't ask is about one's faith. Are you a person of faith? And I think psychiatry's had a bit of a checkered history with faith. And Freud was well known for perhaps not being so enamored of faith systems. But, in my working life, working with psychiatrists who are also people of faith, of various faiths, it's just an interesting thing that people don't often ask, or maybe a bit apologetic if they ask about it, or express it. And that I think it's an interesting perhaps reflection on psychiatry a little bit, that we're being a bit sort of distant from that part. But it's really, really important to people, and to understanding there, as I said, in terms of psychodynamic formulation, understanding a person, ask them about their belief systems, whether they be a particular traditional type of faith system, or their own sort of faith and belief and their moral compass and how they navigate through life. I think that's something that's perhaps a bit underdone.
Mm-hmm. Very interesting. It's very thought-provoking in terms of thinking about how we approach our work and the questions we ask and don't ask. So thank you. Anything else about the chapter in terms of the experience of writing it and reflecting on it now, and where you think we might wind up 5 years from now, 10 years from now in terms of classification?
Well, I really hope that it will be part of what will be happening is an investigation of different ways of diagnosing, and of some really shake up to the classification scheme as it is. And at the very least, some really good research across the binge eating spectrum disorders, because at the moment they're standing in stark contrast. And, and binge eating disorder doesn't even have anything about body image, for example, or weight shape concerns or preoccupations as part of its diagnostic system. And then it's got all these other specifiers which aren't in bulimia nervosa. So at the very least, I'd hope there'd be some shake-up and some really good research coming out that would drive a DSM-5 point something to at least move the disorders of recurrent binge eating to a little bit more of a sensible place.
Well, I am confident that you have asked questions and pushed research forward in ways that have changed the system and will continue to change the system. And for that, we're most grateful for you as a colleague in the field, and certainly people who live with these conditions benefit from your continuing curiosity and persistence. So thank you so much. It's really, really wonderful to talk with you today.
Thank you, Kathy, and thank you and Ruth for really driving this forward. Thank you.